Hello everybody, hope you all are fine. Today we are going to start the coronary circulation and its clinical relevance part 2. So at the end of this session, the participants are expected to be able to describe the coronary anastomosis, explain the coronary dominance, describe the venous drainage of heart, and give a summary of blood supply of heart. And at the end, he should be able to correlate some of the clinical aspects such as coronary heart disease and its investigations, coronary angiography, and treatment of coronary heart disease in the shape of stenting, coronary angioplasty, and coronary bypass surgery. We start with the coronary anastomosis and coronary dominance. First, what is the anastomosis? Anatomical, Anatomically, it is a communication between the two blood vessels through collateral channels. The coronary anastomosis occurs at the following levels. Number one, superficial on the surface of the heart, subepicardial underneath the pericardium, myocardial in the myocardium, and subendocardial, that is underneath the endocardium. Important sites of coronary anastomosis are: number one, between right coronary artery and left coronary artery, that is its circumflex branch near the crux of the heart; between anterior or posterior interventricular arteries at the apex of the heart; between branches of anterior and posterior interventricular artery in the posterior part of the interventricular septum; between conal arteries of the right and left coronaries at the conus of the right ventricle. Anatomically, coronary arteries are not end arteries, but functionally they behave like end arteries. Hence, prognosis is better in slow occlusion as compared to sudden occlusion, because the vessels involved have got proper time or ample time for dilatation to occur in the slow occlusion. The coronary dominance, it is an anatomic variation of coronary arterial supply, notably profusion of inferior cardiac territories. The basis of coronary dominance is that it depends upon the vessel which gives posterior interventricular artery, which supplies atrioventricular node and posterior one-third of the interventricular septum. The types of the coronary dominance are: number one, in 70% of the cases, right coronary artery gives posterior interventricular artery, hence the right dominance. Number two, in 10% of the cases, left coronary artery gives the posterior interventricular artery, hence the left dominance. In 20% of the cases, both the arteries collaborate with each other to supply this inferior cardiac territories, hence the co-dominance. Coronary dominance is a misleading term, as left coronary artery supplies greater part of the myocardium, but in 70 to 80% of the cases, as posterior interventricular artery is a branch of right coronary artery, hence the right coronary dominance. As regard the clinical relevance, coronary dominance is associated with development and outcome of certain diseases. For example, left coronary dominance has been associated with increased long-term mortality in cardiac arterial disease patients, and also it is related with the aortic valve disorders. The venous drainage of the heart is mainly through two routes. One is indirect through the coronary sinus, and the other one is direct through the veins which open into right atrium. First, the coronary sinus. It is the largest vein of the heart and is actually the continuation of great cardiac vein. It is roughly 3 centimeter long and is located in the posterior atrioventricular or coronary groove. It ends in right atrium, and the opening lies in the posterior wall between inferior vena cava and tricuspid openings. Its tributaries are number one, great cardiac vein, which is continuation of the anterior interventricular vein which lies in the anterior interventricular groove, runs upward and enters the anterior atrioventricular groove and continues as the coronary sinus. Second is the middle cardiac vein, which is present in the posterior interventricular groove. Then is the small cardiac vein, which is present in the posterior atrioventricular groove. Then is the right marginal vein which runs along the right inferior margin of the heart. Then are the anterior and posterior veins of left ventricle, which are present on the costal and diaphragmatic surfaces of the heart respectively. The oblique vein of left atrium on its which lies on the posterior surface of the left atrium. And then are the anterior veins of right ventricle which open into the small cardiac vein. The second group are the veins which directly open into the right atrium. First are the anterior cardiac vein, which are 3 to 4 in number and drain in fundibulum of the right ventricle. They open into right atrium through its anterior wall. The second are the vena cordis minimi or Thebesian veins. They are numerous in number and mostly open into through the posterior wall of the right atrium into the right atrium. Third are the small cardiac vein, which may open into the right atrium directly instead of opening through the coronary sinus. Notable aspect is that left posterior coronary groove is occupied by number one, the circumflex branch of the left coronary artery, which carries arterial blood from left to right. And second one is the coronary sinus, which contains venous blood and blood flows from left to right. Notable aspect is that both these vessels carry blood in the same direction. This is the only example in the body where arterial and venous blood flows in the same direction. Another thing to be noted is that all tributaries of the coronary sinus have got valves except the oblique vein of left atrium. Summary of the blood supply of the heart. By keeping in mind that arteries supply and veins drain the area on both sides of their passages, we summarize the blood supply of the heart. First, the major part of right atrium, and in 70% of the cases, the sinoatrial node and AV nodes are supplied by right coronary artery, and this area is drained by small cardiac vein and middle cardiac vein. Number two, a strip along the inferior margin of the heart, that is right ventricle, including the apex of the heart, is supplied by right marginal branch of right coronary and drained by small cardiac vein and middle cardiac vein. Number three, a thick strip on the diaphragmatic surface consisting of adjacent parts of right and left ventricle along the posterior interventricular groove and posterior one-third of the interventricular septum is supplied by posterior interventricular branch of right coronary artery, and this area is drained by left posterior ventricular vein. Number four, a small part of left atrium and adjacent left ventricle and left bundle branch of his is supplied by stem of the left coronary artery and drained by great cardiac vein. Number five, a thick strip on the sternocostal surface consisting adjacent areas of right ventricle and left ventricle along the anterior interventricular groove and anterior two-thirds of the interventricular septum is supplied by anterior interventricular branch of left coronary and drained by great cardiac vein. Number six, major parts of left atrium and major part of left ventricle are supplied by circumflex branch of left coronary and drained by great cardiac vein. Number seven, a strip along the left side of the left ventricle is supplied by left marginal branch of the circumflex artery and is drained by left marginal vein and great cardiac vein. Now we come on to the applied or clinical anatomy. First, the CAD or coronary artery disease. It is a condition in which blood flow to the muscles of the heart is reduced or blocked, which results in chest pain or heart damage and is usually caused by atherosclerosis. Now, what is atherosclerosis? It is deposition of fatty material in the shape of atheromatous plaques along the wall of the vessels, leading to narrowing of the lumen of such vessels. Now, what is atheroma or atheromatous plaques? It consists of mostly macrophage cells or debris containing lipid, calcium, and a variable amount of fibrous connective tissue. Another term is arteriosclerosis, which is quite distinct from atherosclerosis. It is actually the thickening and hardening of the vessel wall, leading to loss of elasticity. Now, the results of reduced or blocked blood flow. If the ischemia is transient, there is the condition is named as angina pectoris. And if the occlusion is prolonged, which leads to tissue death, the condition is labeled as myocardial infarction. The investigation for CAD or ischemic heart disease are: number one, electrocardiograph; number two, cardiac enzymes; number three, echocardiography; number four, treadmill exercise test; number five, thallium stress test; and finally the coronary angiography. A brief review of the coronary angiography. It is a test which uses dye and special X-rays and shows inside of the coronary arteries. How the coronary angiography is performed. First, a malleable catheter is inserted into an artery. May it be radial, brachial, or femoral. And the catheter is guided through iliac artery and aorta up to the heart using X-rays. When it reaches the aorta or the specific point of concern, the special dye, the contrast material, is injected through this catheter, and multiple X-ray images are taken which show how dye moves through the arteries. These X-ray films highlight any blockade or damaged blood vessels of the heart. Lastly, we come on to the treatment of coronary artery disease. First, the angina pectoris. This ailment is treated with the medicines only. Second group is the single vessel disease, where one vessel is involved, or two vessel disease, where two vessels are involved. In this case, either the vessels are dilated through percutaneous transluminal coronary angioplasty, or stenting is performed, which may be simple or with drugs, that is vasodilators. A stent is a small metal mesh tube which prevents blocked artery from reclosing. Third group is the triple vessel disease, where three vessels are involved. In such cases, coronary artery bypass grafting is performed. The process of this grafting is that first the median sternotomy is performed, then superior vena cava and inferior vena cava are cannulated so that venous blood is diverted to the bypass machine. At the same time, ascending aorta is also cannulated so that blood from the bypass machine is diverted to the body tissue. For grafting, the vessels which are used are either the reversed great saphenous veins or internal thoracic arteries. Now, the vessels which are joined or connected through the graft are: number one, ascending aorta, with the right coronary artery for blockade of the right coronary. Number 2, ascending aorta with the circumflex artery for the blockade of the left coronary artery. And number 3, internal mammary artery or internal thoracic artery with left anterior descending or anterior interventricular artery for the blockade in the anterior and interventricular artery. Comments and suggestions will be welcomed. Thank you for listening and watching.